Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Nalha Balata from Roots Community Health Center, reporting for the week of May 9th, 2022. Today I'm going to give an update on the pandemic status, as well as some wastewater sampling updates, and also a discussion about our vaccines. Are they doing what they need to do, and what do we have to look forward to? As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Please submit your questions in the comments, by direct message, or by email to admin@rootsclinic.org. Here in Alameda County, we can see that the 14-day cases continue to climb. Last week when I reported, it was at about 3,800. Now we're over 5,500 and certainly seems to be heading in the wrong direction here. Same thing with our 7-day percent positivity, which is at 5.8%. 2 weeks ago when I reported, we were at 3.9%, then 4.5%, now 5.8%. So it's going up at a pretty sharp clip. We know that this is only people who are getting tested at testing sites and hospitals and so on. And so this doesn't include a large number, we believe, of tests that are being conducted at home and people that are diagnosing themselves at home. And so this is likely all an undercount. So for that reason, some of our other indicators become more important, including hospitalization. So we're going to be keeping a close eye on all of this. Hospitalizations, unfortunately, do seem to be ticking up a bit. Was fluctuating there for a little while, kind of hovering around the 40s, 50s area. It was 43 in the hospital and 3 of those in the ICU when I reported last week. Now we're up at 68 and 8 of those are in the ICU. So definitely this is still fairly low, but again, concerning that we may be heading in the wrong direction, and we will be seeing over the coming weeks if those increases in cases are indeed continuing to result in increases in hospitalization. And this is what we're obviously hoping to guard against now that we do have treatments available, but we know that that requires people getting them prescribed to them on time. So we'll talk a little bit more about that in a moment. Wanted to share the variant proportions. The BA.2.12.1 is continuing to increase. It's now making up about 37% of samples. It was at about 27% last week, so increasing at a pretty good clip there. And unfortunately, we've gotten some information that having been infected with the regular Omicron strain, so the BA.1, is not offering a whole lot of protection against this BA.2.12.1 or the BA.2 for that matter. So although most people don't know what strain they may have caught in that initial Omicron wave that we had this past January, it is unfortunately looking like the antibodies that were made, if you caught that one, are not very good at protecting against this BA.2.12.1. So that explains why we are seeing quite a bit of reinfection. So we need more information to know how everything else is going to be holding up against these new variants, but it's certainly not a good combination of things for it to be both more contagious and also kind of get around that prior immunity from prior Omicron infection. Fortunately, the vaccines seem to be holding up overall, but I'll talk more about that in just a moment. And in talking about variants, one of the proposed uses around the wastewater sampling is just looking for increased cases, but also wastewater can be sequenced in order to look for new variants. So first I'll show you, and this is from the state's dashboard. This is a bit newer dashboard, and the link is in the post. But we can see that East Bay MUD's concentration of SARS-CoV-2 is definitely heading up pretty sharply there. So what does that mean? Well, we're still learning how to put this all in context. And a great article came out recently in Emerging Infectious Diseases. And it did kind of a closer look at wastewater sampling, and this was in Oregon. And basically, they looked at wastewater sampling from March to mid-May. So this is really like hot off the presses. And to kind of get to the bottom line here, what they discovered was a new variant that they hadn't discovered before in that region. And by taking together sort of the wastewater information and then taking the community level information, the testing information, and all of the sequencing that they were doing, what they determined is that the wastewater sampling actually picked up this variant 12 days before they picked it up in the specimen collection. So I think that this is reassuring and maybe can make us a little bit more hopeful about how useful the wastewater sampling might be. I think at this point we don't have good kind of standardization across the board or consensus about how we're going to use the wastewater. So for now, we're just kind of watching it and anticipating that when the concentration goes up in wastewater, it will also go up in the community. But I wanted to point this study out just because I think that 12 days of lead time for detecting a new variant might be an indicator that that's the kind of lead time or early warning system that wastewater sampling may be able to provide us. So a lot remains to be seen here, but that felt like a little kind of piece of good information there. Now, I want to spend a little time just talking about the vaccine and about, I'm just getting a lot of questions about, should I get this booster, or even just very strong feelings about getting the booster, not getting the booster, calling it a booster, not calling it a booster. And so I wanted to, and then should we get it, and what do we base that decision upon? So I put together a little table to kind of help us through this, because I think that the answer depends on the age and situation. And I also am finding, the more I talk to people, that very few people have heard about the new schedule that I discussed last week. So it's all here in this table now, and we will be posting this separately as well. So that's something that you can share if needed. And this is based on the best information that we currently have. And basically, we can see that it's different depending really on the situation and the age group that we're talking about. So I think one thing that is important to talk about, because one of the things that I feel like gets a little frustrating in general for everyone is, how many boosters are we going to have? Are we just going to be saying a new booster, a second booster, a third booster, and how long will that go on? And as I mentioned before, I think really what it is going to come down to is that we're going to get more sophisticated with all of the information that we now have about what do we really consider a primary series. And do some people need 3 doses in the primary series? Well, yes, we know that already. If you are someone who is immunocompromised, then your primary series was actually 3 doses. And so we're still seeing a lot of confusion about this, because people are saying, well, I already got my boosters. Well, no, if you are immunocompromised, then you should have gotten 3 doses for your primary series, and those would have been the first dose, and then the second dose would either be in 3 or 4 weeks, depending if it was Pfizer or Moderna, respectively. And then you would have gotten your subsequent dose 28 days after that. So right now, if you're immunocompromised and you haven't gotten vaccinated yet, well, first of all, I'm very concerned about you. I want you to get vaccinated, but your primary series is 3 doses. So that doesn't even count the booster. And for the booster, you can get your first booster after 5 months after the primary series, and you can get your second booster after another 5 months after the primary series, after the first booster, excuse me. So as you can see, if you are immunocompromised, then at this point, it is fathomable that you would already be getting your 5th dose right now, or have gotten your 5th dose already. And that would mean that you were up to date on your vaccines. That is for immunocompromised. Now, when we talk about individuals over 65 years of age, Then we are going with that original schedule, 2 doses, 3 weeks apart for Pfizer, 4 weeks apart for Moderna. And then that first booster would be after 5 months, and the second booster at least 5 months more after that. So this is about that time because, as we know, most people over 65, well, they were in the first tiers for getting vaccinated in the first place. So for many people who are over 65, they should be working on that fourth shot by now. And for those who have waited until now, this is certainly the best protection. This is the group that we are most concerned about being hospitalized or dying, particularly if unvaccinated. And at this point, also, we're concerned if that booster was too long ago. So that is when that second booster will come into play. Now, when we get into the younger age groups, this is when you start to have a little bit more, I would say, flexibility or a little bit more kind of clinical discretion, if you will. But I think it's important to say, if you are 12 years old to 64 years old, the recommendation is actually that your doses be 8 weeks apart. So this is a significant change from that 3 to 4 weeks apart. And so this is if you're not immunocompromised. We're not too worried about you, doing poorly. We don't need to get you rapid protection for purposes of a trip or some type of interaction that you're going to do. So if you're not vaccinated yet and you're 12 to 64, it's important to note that the recommended schedule is 2 doses, 8 weeks apart. And this is going to reduce that small risk of myocarditis. Now, remember, the risk of myocarditis is much worse if you catch COVID. That it prevents you from catching COVID is a huge protection, not only from myocarditis, but a number of other things. But this is also a more optimal schedule for having a better immune response. Now, I think it's worth pointing out that we don't have a lot of experience or time under our belt with this new series. This just kind of came out quietly in late February, and it hasn't necessarily been adopted widely. This 2 doses, 8 weeks apart. So the question is, if you have 2 doses, 8 weeks apart, are you going to need as many boosters as those of us who got our doses probably too close together? Remember, we got them that close together because we were really rushing to try to get everyone as protected as possible, as quickly as possible. But we're not in that situation anymore. So if you or folks that you know haven't gotten vaccinated yet, I think it will be reassuring for them to know 2 doses, 8 weeks apart, and then they're going to get their booster after about 5 more months. Now, I've been getting this question about people who are 50 to 64-year-olds. Should I get the second booster? So I think it's not as clear cut here. I think if you have underlying conditions, it would be much more likely to want you to go ahead and get that second booster. If you are immunocompromised, remember, you should have already gotten your third, fourth, and now be working on your fifth. But for people who are 50 to 64 with no underlying conditions at all, and it's been 5 months since your first booster, should you get it? And I think that the evidence that we got from Israel was very clear over 65 years old. I think there's very little downside in this age group. We haven't seen a safety signal in this age group, so it wouldn't hurt. Is there a reason to wait? Well, I'm going to get into that in just a little bit. But right now, there isn't an objective reason to wait. We are already heading into kind of a surge or a small wave, whatever you'd like to call it. So being prepared and ready for that to hit us full on is not a bad thing. If you're going to be doing some kind of high risk activity, some of you might have a conference planned in a month where there's going to be people indoors gathering, and it may be a higher risk activity. Do you want to get vaccinated maybe a couple weeks before that for optimal protection at the time of the conference? I think these are reasonable things to consider. These aren't formal guidelines, but this is sort of where we are in the grand scheme of things. And for 5 to 11-year-olds, it is still 2 doses, 3 weeks apart. Remember, the Pfizer is the only one approved in this age group. There is no booster approved yet for this age group, although we are anticipating this to be considered by the regulatory bodies coming up pretty soon here. And for the 0 to 4-year-olds, of course, unfortunately, we still do not have anything approved. We are waiting on that. And so that's kind of the rundown about the vaccination. And I think one of the things that we've kind of said repeatedly is that the purpose of the vaccine is really to prevent from the most severe outcomes. But we did really get spoiled by the vaccine initially, where it really was preventing you catching it in the first place and transmitting it. But we just don't have that situation anymore, unfortunately, with the Omicron variant. So that is bringing up the question frequently about, should we have an Omicron-specific vaccine? Should we wait for an Omicron-specific vaccine? And we've got a little bit of an update around that. So there were several studies, actually 4 different studies, that were looking at an Omicron-specific vaccine from both Pfizer and Moderna. And they've started clinical trials in people, but we've got some kind of early data from some rhesus monkeys and some mice trials. And what these studies showed was that the Omicron-specific booster and the regular booster, the same one we're dealing with now, really kind of caused a very similar response. No significant difference was found between the Omicron-specific booster or just the regular vaccine that we've been getting, regular booster, on 2 important things, both the antibody response, remember that sort of initial response that we get, but then also the second line of defense, the memory B cells, the ones that kind of wait around until you get presented with it again and then go ahead and make more antibodies. So both the antibody and the B cell response were preserved with the regular vaccine compared to the Omicron-specific vaccine. So I think this is good news. It's reassuring that the current boosters that we're getting are getting the job done. And we'll wait to see what the clinical trials show. But I think this is early evidence that tell me 2 things. One is that we can be satisfied with the booster that we've got for now. 2, I don't think that the manufacturers are going to be super motivated to put this out if the difference is not significant in how well it does. So that makes me wonder how quickly, even if they decide to move forward, how quickly it would even happen. And the FDA's committee, the VRBPAC committee, on the 28th, they are June 28th, so actually in over 6 weeks, they'll be continuing a discussion that they started last month about what we should be thinking about the strain composition of COVID vaccines to meet the needs of public health. So they're going to talk about it at the end of June. So I would not be waiting around for this. I don't think this is really in the stars anytime soon. And if you are someone who is in those categories that could benefit from an additional booster, I would certainly not be using the strain-specific vaccine to be your reason for waiting. I would make that decision independent of any information about that. And by way of additional updates on the vaccine, on June 7th, so that is coming up fairly soon, the VRBPAC is going to talk about the emergency use authorization request for Novavax, and that is a protein-based vaccine. It's very different from the other vaccines that are approved here, mRNA and Johnson & Johnson, which is a adenoviral vector vaccine. This is kind of a traditional type of technology. It is approved, and Novavax is approved in several other countries. And so we are just waiting for that here. And I think it will be nice to have some variety for those who, for whatever reason, would prefer it. And I don't have all of the data yet, hasn't been released yet, but that's something that I'll certainly be waiting for and reporting back on. And last but definitely not least, by way of vaccine updates, is that there are several for children. Both Pfizer and Moderna have things in the works for our younger people, our 0 to 4-year-olds. And there are some tentative dates that the FDA committee has set up to discuss these. They are on June 8th and the 21st and 22nd. So I'll be saving the date for listening to where they're going to land as far as our vaccines for our only completely unvaccinated population, our under 5-year-olds. And so lastly, I just want to touch on treatment. I also made a similar regarding treatment, also by age and situation. And so treatment is going to be after you've tested positive for SARS-CoV-2. What do you do? Also getting lots of questions about this. Should I really take it? Do I really need it? What should I do? So here's a general guideline. If you are immunocompromised or over 65 and over, then treatment is generally going to be indicated for you because you are at high risk of progression for severe outcomes, and we do not want to see that happen. So if you are 65 and over or you're immunocompromised, then we are likely going to be recommending treatment. And the first line of treatment will be Paxlovid, the pills, got to start them within 5 days. And second line, or the second choice, would be remdesivir. Now, the place where it starts to get a little bit trickier is in the younger age group, so kind of between 18 to 64, where we've got treatment options, but maybe you're not really at risk. And so do we want to do the treatment? Do we not want to do the treatment? This is where we're really going to need your doctor to help make the decision. So if you've got underlying conditions, if you're not vaccinated, so if you were between 50 and 64, and let's say you're not vaccinated and you've got diabetes, then we're going to want to treat you. So this is a little bit of an individualized decision. Now, let's say you were vaccinated and you have diabetes and you feel okay. Should you get it? This is a good conversation for you to have with your doctor because right now there's really not a kind of hard and fast guideline. The treatments are available, so it's no longer about prioritizing the people most likely to get sick. We have a little bit more flexibility here, so please don't assume that you should not be treated just because you're not 65 or over or immunocompromised. You still may be a good candidate for treatment, and it is certainly preventing some of the more severe outcomes. And it really was mostly studied in people who were not vaccinated, and there's a very dramatic improvement. With more time, I think we're going to see how big of a difference it is really making for, let's say, vaccinated people who are fairly healthy. But again, this is where I think talking it over with your physician is a good idea. Now, for our 5-year-olds to 17-year-olds, this is where if you are high risk, if your child is high risk, if they're unvaccinated, then we are going to be looking to treat. And so if they are 5 to 11, remdesivir is actually the only treatment that's available to them. And if they are 12 to 17, then they can do the Paxlovid. And second line is going to be the monoclonal antibodies. And last but not least is our littlest one, 0 to 4-year-olds. Of course, they're all unvaccinated. So if they are high risk, then remdesivir is the only treatment option available to them, and it goes down to 28 days or 7.7 pounds that we can use the IV remdesivir as outpatient treatment for those that are at high risk. So still a little nuanced. I think it's pretty clear for certain situations, and for others it's going to require a little bit more decision making. But don't let the thought that it's scarce be the reason, because it's not scarce. It's actually quite available at this point in time. But having said that, we don't want to give it if someone doesn't really need it. So this is where there's some decision making going on. So now that we are kind of in the midst of graduation season, in the midst of prom season, really going to want everyone to be paying attention to how to make themselves and their loved ones be safer, because we are definitely seeing that SARS-CoV-2 is circulating in our environment. It's a lot more around now than it was several weeks ago. So that is an unfortunate bit of timing that we're going to have to deal with here. But hopefully the weather cooperates and we can have most of our gatherings outdoors, especially the part where we're eating and drinking or taking off masks. Outdoors is always going to be safer than indoors. Having said that, if you're in close proximity talking, someone's loud, they're yelling, go ahead and pop on a mask so you can prevent the droplet transmission. And I had a couple questions about what do I do with all these cloth masks? I have some cute masks. What do I throw them away? I personally have not thrown away my cloth masks, but I consider them only useful for preventing droplets from landing on my mouth and nose. So that's really only outside. So they're kind of like my outside mask. So I keep an N95 or a KN95 and a cloth mask for gatherings where I'm outside. If I have to go use a restroom or go indoors or when I'm going in or out in any common areas, then I am putting that KN95 on, making sure it's fitting snug before I brave the indoors. But if I'm just outdoors, then I might take my cloth mask and just pop it on. If I'm in close proximity with someone, if I'm eating or drinking, obviously I'm taking it off. And I'm okay just normalizing that as part of my activities, and then I can feel safe and comfortable doing these things. And if you are going to be one-way masking, that means you are maybe in a higher risk situation, you are indoors, others are not masking, you are relying on your mask to protect you, you are going to need a high filtration mask like a KN95 or an N95 mask. So please make sure that you get some that fit you well, that they're comfortable, you can keep them on, and that there's no gaps around there, that you have a good seal. And if you must be indoors, shorter time is going to be safer than a longer period of time. And if you're going to be in small spaces, like a car, please open those windows. We're hearing a little bit of an increase. Maybe it's anecdotal, but in people riding together and catching COVID, it's a tiny space. It doesn't tend to have good air exchange unless you're keeping the fan running all the time and you're sitting close to someone. So if you keep the N95 on or KN95 on and unroll the windows, then you will be doing a lot to protect yourself. And that, of course, goes for you being inside of Ubers and so on, because now there's no longer any requirement for the drivers to wear masks. So rolling down the window is your best bet there. And of course, to prevent the most severe and tragic outcomes of SARS-CoV-2 infection, vaccination and booster are still incredibly effective at keeping you out of the hospital and keeping you from dying. At this point, I do not want to hear any more COVID deaths. I don't think we should hear about any more COVID deaths. I know that we're going to, unfortunately, and it will be just based on different disparities because we're already seeing that happening. But at this point, we've got vaccination, we've got boosters, we've got treatment. We should not lose anyone else to SARS-CoV-2. So please remember not only vaccination and booster, but also tests so you'll know if you're positive early and get that treatment if you're someone who would benefit from it. Get a primary care provider. If you don't have one, don't wait to be scrambling until you really need them. And eat a balanced diet, get some exercise, take a multivitamin supplement, consider additional vitamin D supplementation, manage your stress, and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us. Look forward to seeing you again next Tuesday at 10 a.m.